Good afternoon, everybody, and welcome to this PCR webinar focusing on a physiological guidance during treatment of a bifurcation lesion. I'm Jens Lassen from Odense, Denmark, and in the PCR studio with me I have Dr. Adrian Banning from Oxford, UK, and Dr. Benjamin Fourier from Grenoble. And to get started, would you, Benjamin, tell me why this question about physiological guidance is so important to you?
It's interesting because actually, and recently, the new physiological wire just changed my practice to treat bifurcation in the way to simplify it and sometimes to avoid a side branch stenting in my bifurcation treatment. But it's only with this new and very talkable second generation fiber optic wires.
Okay. And Adrian, what is your main objectives in this session?
Well, I think we've seen how physiology has changed our practice, how we can no longer just rely on the angiogram. And in Syntax 2 in particular, we started to use physiology in multivessel disease. We started to understand that quite a lot of lesions didn't need treatment at all, and that some lesions were going to need treatment, but we needed to make sure that we did a great job to get rid of all the ischemia. And I think what we're starting to learn now is a little more about how we optimize our results, how we make sure we've done a good job. And I think bifurcations are obviously a classic example of a complex lesion where ultimately more information, both about how to treat it and how to make sure we get a great result at the end of the treatment, is going to be really insightful.
Excellent. And that is really setting the scene for what we are going to go through today. Actually, the main issue is to appreciate the philosophy of how we do provisional stenting in a coronary bifurcation. But today also to share the planning and interpretation of the lesion by physiology and set physiology into perspective in where it could guide us during the provisional stenting stepwise approach. There are different steps which is really important and where we need a guide. First is the initial lesion assessment. After that, evaluation after main branch stenting, and of course consideration of the side branch ostium in that respect. And finally, the final assessment. And this is the learning objectives for today, and we will run through it during the next hour. And to start on the philosophy of provisional stenting, Adrian, could you take us through the basic principle of stenting?
Well, as you know, Jens, the European Bifurcation Club has been running for nearly 15 years now. And over that time, there's been an evolution of the strategies that we have recommended to treat bifurcation. But there are certain principles which have remained strong throughout. Those principles are that we need to keep the procedure as simple as we can and as safe as we can. We need to limit the number of stents that we use. But perhaps most importantly, we need to respect the original bifurcation anatomy and try and reproduce it. You know, arteries start big and get smaller. They're not the same diameter at any length, and we need to respect that anatomy and try and reproduce it. And ultimately, when we've finished the treatment, we need to make sure that our stents are well opposed, well expanded, and that there's minimal overlap of stents. So I think if we try and stick to those 4 principles with our bifurcation treatments, our outcomes will be good.
Excellent. And as you can hear, there are stepwise approaches in the provisional stenting. Coming back to the anatomy, and of course after that the physiology. But first the anatomy. Benjamin, could you talk a little into why it is important to take care of the anatomy of a bifurcation?
So it's quite simple, and as Adrian just said it, Mother Nature make a bifurcation like that. The proximal vessel is bigger than the distal vessel when this vessel is giving some branches. We all know that, but it's obvious sometimes, but we have to remember it. Bigger vessel in the proximal part, smaller vessel, smaller diameter. And if you want to go further, there is the Finney's law, which is very interesting to calculate both of the side branch and the main vessel.
I would like to stay a little in this discussion. Adrian, stents are tubular and vessels are not. Is that a problem if we take nature into consideration?
Yeah, I think one of the mistakes we tend to make is we tend to, at least historically, there was a tendency to size our stent to the proximal vessel rather than to the distal vessel.
Yeah.
And that meant that we overexpanded the vessel at the distal segment, and that inevitably distorts the carina of the bifurcation, shifts the carina of the bifurcation, and creates a narrowing at the side branch ostium, which wasn't there before. So one of the key principles of bifurcation treatment is to size our stent to the distal vessel diameter, and then expand the stent proximal to the bifurcation to the optimal size with a procedure which we call POT, so proximal optimization. So that recognition that the stent should not be tubular, it should be smaller in the distal dimension and bigger at the proximal part, is a really important recognition.
So Benjamin, coming back to Mother Nature again, and the tapering nature of the main vessel, if we overdilate the distal part, do we actually introduce a narrowing of the ostium of the side branch then?
Probably by carina shifting, as we know. The stent gonna make the carina shifted on the side branch, and you will have at least angiographic stenosis of your side branch. I mean angiographic, but we don't know about physiology about this side branch.
So actually, the evaluation of that side branch ostium is a bit difficult when it happens in the procedure.
Exactly.
Yeah. So actually, already here, we have a balance between the nature and the technology, and maybe the physiology behind, because as every stenosis we have learned, it's not necessarily the same that there is an angiographic stenosis as there is a flow problem distally to that stenosis. So again, for the audience, this is something to underline the importance of taking care of anatomy in the philosophy of provisional stenting. But before we really start on stenting, we also need to evaluate the lesion. And there are different ways of evaluating lesions. One of the setup that is put forward by the European Bifurcation Club is actually the Medina classification, which is very, very simple. It states is that there is either, if there is a stenosis, it's a 1. If there's none, it's a 0. And there are differences in the interpretation, but it's basically based on an angiographic evaluation. And Benjamin, does that causes a problem in interpretation and angiogram?
Yes, it does. As you said, it's angiographic definition, but we don't really know what about physiology. And we all know that focal lesion, ostial lesion are more tended to be treated by an interventional cardiologist, but the FFR is more often negative on this kind of focal lesion. Contrary to a long lesion, long LAD lesion, for example, which are not obvious, but more oftenly positive FFR. So it's really a different definition, anatomy and physiology, and that's why it's very important to assess from a physiological point of view.
Yes, originally the Medina classification was introduced to have a kind of guideline how to categorize a bifurcation when you put the bifurcation into a study, to make the comparison between studies more easy. And we were discussing true bifurcations versus non-true bifurcations. But basically, on a very simplistic nature and based on more or less the angiographic view, which could be a kind of a personal view. Do you have a comment here, Adrian?
No, I think it's a very easy way for us to talk to each other about bifurcations. One of the problems we had was it was quite difficult. So this 1, 1, 1, which means that all 3 segments of the bifurcation are stenosed. The first one being the main branch, the next one being the main branch, and the third one being the side branch. It means we all know what that means. Whereas a 1, 0, 0 is clearly something different. So I think the Medina classification makes life a lot easier when we're talking to each other about whether this is true bifurcation with disease of both branches or whether it's not. And I think that really is a very useful language for us to talk to each other about, particularly clinically.
Yeah, so it was a good basic frame for evaluating bifurcations. But Benjamin, you tells us that we may need some guidance from physiology to evaluate what we see. Is it really significant to some extent? And I remember the early days in the European Bifurcation Club where we were discussing when to treat a side branch or not. We were discussing when is that side branch significant. And actually we ended up discussing it was significant side branch if the operator don't want to lose it. But it has nothing to do with physiology. Physiology have basically changed our mind to some extent. But Adrian, there is a lot of different ways of evaluating physiology. There are different indices. There are hyperemic FFR measurements, and there are resting indices. What should we do in this setting?
I mean, it is confusing, isn't it? And
yeah.
It's in the last, we started off with FFR, we then had IFR, and now we've got maybe 3 or 4 other resting indices. The recent guidelines have been pretty clear. I think any of those resting indices or FFR is an excellent way of trying to decide whether we need to treat a lesion. And personally, I don't really mind whether we're going to use a resting index or a hyperemic index. I think the thresholds are clearly different for each. 0.89 for most of the resting index, 0.8 for FFR. But it doesn't matter which one we use. But I think what we're not doing is using enough physiology in our interventions to be absolutely sure that we need to treat the lesion in the first place. And I think what we'll hear in the next 5 or 10 minutes is important, which is there is data looking at the physiology in side branch intervention, showing that actually the angiographic nipping that you see quite commonly during an intervention of a bifurcation is not physiologically important. And so I think that's one of the ways in which the physiology is starting to impact on the way in which we perform our bifurcation techniques.
Yeah, actually when we were using FFR-guided PCI in non-bifurcation lesions, it learned us a lot about the angiographic interpretation and what really was a significant stenosis when it came down to flow. But embarking in physiology guidance in a bifurcation is a bit different. It's a bit more complex than in straightforward, narrow, smaller stenosis. One thing we actually need to address is that the manipulation of a wire is actually quite important when you're doing bifurcations. And do you have an opinion on that, Benjamin?
Exactly. It's maybe the main reason why the interventional cardiologists are not using enough the pressure wire in bifurcation. It's because it's a more technical problem. If we would have a fiber optic wire which can be used safely and very simple, we could use more and more into these bifurcated lesions.
So kind of working like a workhorse wire.
Exactly.
Yeah, I mean, I think that's right, isn't it? I mean, I think we're already a little bit tense about treating a bifurcation, and we don't necessarily want to make it even more complicated by using a wire that we don't really trust. And there was some data, certainly from the first generation FFR wire, where there was dissection in some of the trials and some wire fracture when they were jailed, and they weren't necessarily a friendly wire to use. And I think there was a sense that we were taking a difficult lesion and perhaps making it even more difficult by using something that we weren't very comfortable with. So it's interesting to hear that perhaps the wire technology is moving forward, and as I said, as a consequence, perhaps we can start to use some extra information with regard to our clinical strategies.
Yeah. Actually, I would like to come back to the stepwise nature of a bifurcation treatment. There are different steps where we need to address and have a guidance when we have to consider the physiology as well. Before we really embark on that, I think we need to discuss a bit more when a side branch is significant. Because the main problem is, if you're in doubt, we need some guidance. And of course, physiology is what we're discussing today, and it will guide us a lot if a physiological measurement is negative. If it's positive, we may have some discussion as we can address later on. But what I really like to underline is that a bifurcation is not always just a bifurcation. There are the left main, and there are the other bifurcations. Do you think that there are differences when we should discuss physiological guidance and treatment of left main and other bifurcations? Adrian?
I think they inevitably are. I mean, there are anatomical differences between the left main and other bifurcations. It's clearly always going to be bigger. It's always going to have more calcium. It's always going to have the issue of the ostium. And importantly, the circumflex is always going to be a big branch. It might be a massive branch if it's a circumflex dominant circulation, but it's always going to be a big branch and be important. And we also know that the ostia, particularly the circumflex, is resistant to expansion and has a high restenosis rate. So in a left main bifurcation, you're really dealing with a very demanding circumstance. And certainly I think it's probably sensible for us to categorize the left main bifurcation and all other bifurcations, because I think ultimately there are differences in how we approach them and the sort of strategy that we're going to have. Just keeping the circumflex open, particularly if it's circumflex dominant, is going to be insufficient, whereas it might be the right thing to do in a complex second obtuse marginal bifurcation, just making sure we don't lose it. So I think we do need to categorize it between left main and non-left main bifurcation.
Yeah, so actually there are things in the left main which goes beyond the physiological measurement when deciding to embark on the side branch or not.
Exactly.
So, but does it work the other way around in other bifurcations? That there are maybe side branches that, well, it's difficult to evaluate, but give another consideration, Benjamin.
That's an excellent question, and I hope we could answer to it after the case, because as I said, I changed my practice. I used to do 95% of casings balloon inflation after bifurcation treatment, and due to physiological assessment, I changed my practice. So maybe we could jump into the case to see that.
That was really an excellent idea. So what we have achieved until now is just discussing the stepwise nature of provisional stenting, the evaluation based on physiology. We'll go much more deeper in details with that, but also underlined that we use physiology in a broader sense and discussing the guidance from it, not the specific indices or hyperemic or other values of it. And finally, we are not discussing how to engage in left main stenting today. We are going to other bifurcations, and having said that, I think we should change to the case and do some practice discussion. But actually, just before that, we have an excellent question from the audience. And it's very nice that you raise questions, and we are very happy to discuss with you. So thank you very much for that. The question is there any differences in FFR estimated with a microcatheter versus with that estimated with a wire-based technology? Which is actually a quite long-haired question, but...
well, there shouldn't be.
There shouldn't be. Well,
I think one of the advantages of the microcatheter, obviously, is you can use your workhorse wire to get into that difficult branch, and that's probably the answer that people want to hear. That it can be a useful way of trying to access it if you're not confident with your wire to get round a tortuous vessel or a steep angle. One of the things we have to be careful about with all pressure wire technologies, you can get kinking. If the angle is very tight, then you get a false positive pressure wire result because you actually kink the vessel because of the tortuosity and straightening it out. But generally, I think, again, in the same way that I think hyperemic and non-hyperemic are broadly the same, I certainly think microcatheter and wire-based technologies are broadly the same, and I think you use which you're comfortable with.
But Benjamin?
Yeah, but I would like to ask to Adrian that the diameter of the microcatheter is different from the wire. So in small vessels, maybe there is an issue with the value of FFR, maybe.
Yeah, I mean, to be honest, I wouldn't be using a microcatheter down there in a tiny vessel anywhere where it's that small and that tight, but there is a theoretical anxiety about that, which you're right to raise, I agree.
But anyway, I think we also have to underline that physiology assessment is important help, important guidance. But actually we are not on very safe ground when we evaluate all the gray zones. So there are, of course, it's important to say it's a help and it can guide you in your decision making, but it may not give you the answer. It's just a guide, and I think that's an important...
it's always been an element of art within our science, right?
Which is nice, isn't it? But let's be practical and go to the case.
So this is a 65 years old woman, very active. She has a history of smoking, family history of coronary artery disease, and she described a recent exertional angina, class 2, and a recent dyspnea also. She has a positive stress test, that's why she come into the cath lab, and she has a normal LV function. And we will be happy to have the top of the audience. So this is the angiogram. The RCA is moderately diseased. This is the caudal view, RAO caudal view, with a tight stenosis of the proximal circ at the bifurcation. This is the cranial view also, with the LAD. And this is the same view, cranial view, and at least the caudal, the spider view. So Jens, what would you say? It's a single, double, or triple vessel disease?
Well, I think that's an excellent question, actually. So I will pass it on to the audience, and I'll just ask you in the audience to make a small pause, look to the angiogram, and try to, well, take it in and make your own decision on, is this a 2, 3, 1 vessel disease? What is the main problems? And give it a thought. And then I'll actually pass it over to Adrian to hear your opinion on this case.
I mean, it's very much, it's probably a syntax 2 type case, really. Angiographically, there is some atheroma in all 3 arteries. The right coronary disease is equivocal angiographically, and I would speculate that's likely to be pressure Y negative.
Mm-hmm.
The LAD disease is focal, but it's the LAD, and it looks quite tight. It's on quite an angle. So I think you'd need to assess that physiologically to be sure. The circumflex disease looks really to be very significant. I would expect that that's the culprit lesion for her symptoms. It clearly involves a bifurcation, I think it's a kind of 1-1-0 bifurcation, depending on how you categorize the, which is the main branch. But I think pressure wire probably to LAD and treatment of the circumflex.
Mm-hmm. Yeah. We have a question from the audience. They ask us, do you feel that the circumflex osteum is diseased? But maybe we should pass it on to you, Benjamin.
It's a good question. By the way, there is disease on the proximal circ, and we will probably evaluate it.
You saw it in that right-sided view, didn't you? Just the proximal, and then certainly in that view there, the spider, you certainly see there is some atheroma there.
Exactly.
Yeah.
That's why we did that case in 2 steps. The first, we must admit there is a small disease in the RCA. We didn't assess FFR in that RCA, which was non-significant for us. But we assessed the LAD. By the way, it was on the curvature, but the FFR was positive at 0.6, and we didn't assess at the baseline the FFR in the circ. It was obvious that it was highly significant.
Yep.
So with this measure, we could do a syntax score, which was at 22, mm-hmm. and we could discuss with the heart team what will be our strategy to revascularization. So,
I mean, it's quite a. The LAD disease is very focal, isn't it?
Exactly.
And you would expect to get a good result with a stent in the LAD. Clearly, the circumflex disease is slightly more complex, but you would think that we would be looking for a good result. I would contend a comparable result with surgery with a much smaller procedure.
Yes.
And it was FFR positive. Of course, we can discuss if it was a difficult measurement of the FFR in that respect, but since it was in your hands, I believe it was done very properly. So
it was quite clear. 0.6 is not in the grade.
And it was a clear drop when you have the So of course it's positive, and we do have a question about tandem lesions in FFR measurements from the audience. I thank a lot for that question. I think we will discuss it in 5 minutes or so, where it fits very, very well into the case. But maybe we should just discuss, should we embark? The heart team actually concluded that the right was diffusely diseased but need no treatment, and PCI was a way of go. So
I guess the question is whether we do them both at the same sitting,
exactly,
which one to do first. I think if we were in Oxford.
But Adrian, maybe we should give the audience just a split second to think if they would do the procedure in one stage, same session, or they will stage it and maybe bring the patient back after a week or two to do the rest. And while they're thinking, we can hear what we would do in Oxford.
Well, I think there are local factors sometimes, and I think it does depend a little bit on what your practice is and what your reimbursement is, perhaps. From our perspective, if it's a simple lesion, which it appears to be in the LAD, and we get a perfect result, not using too much contrast, we would try and do it all in one sitting. I think that there is a benefit to the patient if we can do it all in one sitting. Clearly, the patient needs to know that we're not definitely going to do it in one sitting, but and we must aim for a perfect result in every lesion. I think the idea that we do two quickly in order to get to the third lesion and don't do the first two quite so well is a bad one. But I think in this case, we would probably feel that it is reasonable for us to treat the LAD and then move on to the circumflex, assuming that we got a good result.
Yes, and what is your perspective on this discussion?
Like Adrian, in Europe, there is very many different practice, and it's very different from a country to another one. So we must admit that we treat the most simple lesion, which was bifurcated lesion of the LAD in one stage, and after we treated for the complex bifurcated lesion of the circ, after a washout period of 15 days in that case.
Yeah.
So we will jump into the setting of the PCI if you want.
Yes.
It's one of the advantages of PCI. We can come back, and it's an important point. Then certainly in Syntax 2, we saw much more staged procedures than we had in the Syntax trial. Very much in that kind of mindset that trying to make sure we do a great job on each lesion, and sometimes that means that you can't do everything at once. Within Syntax, the original trial, we were really encouraged to try and do complete revascularization, all in one sitting, quick as you can, 12 stents, bang, 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 bang. Well, inevitably, some of those stents were not put in properly, and that's just how it was.
For me, it's a key point. To do a good job, you have to be ready, you have to be prepared, prepare your strategy, your material.
I think that is an excellent take-home message, is that you don't really need to, plan the procedure to be staged, but you need to plan the procedure to be done in a proper way, and the setup around it doesn't really matter as much as the job done in the lesion. So I think that's really a good way of putting the PCI business forward. So anyway, let's move on with the case.
Okay, so this was the still frame, and so we forgot to speak about the.
Well, I think you treated the LED, didn't you?
Yeah, we did.
And then really we needed to decide what was the best approach to that lesion. And I think it looked to me as if, it depends a little bit what you call the main branch. The first obtuse marginal had definite disease at the ostium. There's clearly a critical disease of the main branch, then osteal disease of the OM1, but less disease in OM2. So I would probably say that's a 1-1-0, 1 being the main vessel, 1 being the obtuse marginal 1, and 0 being the vessel which is coming down towards 5 o'clock. And so my strategy would be, if you go on the slide, to do the provisional approach. So I'm going to put 2 wires in. I'm going to pre-dilate the main branch. I'm going to size my stent to the distal vessel, and I'm going to place a stent. And you see in the second cartoon there, the impact of putting a stent in which is too small for the main parent vessel. But then you optimize that by bringing it out with your pop balloon and making it fit the main vessel properly. And you can see how that deforms the stent and pushes the stent struts across the side branch, providing scaffolding of the side branch. And if you do that well, particularly if you're careful about the positioning of that pop balloon, then it's much less likely that you'll get either carina shift, meaning that you generate a stenosis by oversizing your stent, or you're going to disrupt lesions in the side branch. And one of the things that's been debated over and over and over is, should we be pre-dilating the side branch before we place our stent? Certainly in this case, where there doesn't appear to be that much disease in the smaller branch, the side branch, I certainly wouldn't pre-dilate it. So for me, I'm going to put 1 stent in. I'm going to size that stent in length long enough to make sure I can do my pot safely. So I've got to have enough stent in the parent vessel proximally to be able to put a pot balloon, which is bigger, without damaging the vessel more proximal. So the stent's going to be slightly longer than you might anticipate, so I can do my pot balloon safely.
How long actually?
Well, it's got to be at least 8 or 9, hasn't it?
Because of the balloons.
That's
yeah.
right, exactly. And with these non-compliant balloons, they do have a sort of little shoulder as well. They're quite bulky little balloons, aren't they?
Yeah.
And I think one of the things that you sometimes find travelling around is people don't have sort of 4, 5 and 5 by 8 balloons or by 9 balloons, and we need to get these balloons, particularly if we're treating the left main.
It's really important there. Well, this is a very nice setup for provisional stenting, but it's quite risky when you have put in the stent with respect to the distal diameter, isn't it? If you lose the wire, you have floating stent in the proximal part. So, of course, we have to be careful in that setting when doing the pot. So that is one of the risky steps, isn't it?
Yeah, but I think, wire attention is always important. There's nothing more important than protecting our wires and making sure we put them in the right place. And that's one of the fundamental things that we must never forget.
And what we teach to the fellows.
But so if that happens, you've got to go through in the loop, right?
Yeah. So let's carry on with the case and
so
see what you found.
We choose a right radial approach with a 6 French guiding catheter, sheetless fashion. We place a short XB 30 in the left main. And first, we choose, as Adrian said, the main vessel, which was the circ to the OM1. We flush and equalize this wire, which was the Opsens wire, which has a 35 millimeters long radio opaque parts. So we flush it, we make the 0, and after we're gonna assess the side branch physiology here. So we reconnect in order to assess this, and we disconnect and reconnect many times in that case, I think a dozen of times, and there was we never encountered any drift. So this is the first assessment of the PDPA value, which was 0.45, so it's quite obvious for us, and we make also an FFR, which was very positive.
So that's reflecting the disease proximal to the bifurcation and possibly what's happening at the ostium of the side branch. So it's no great surprise that that's very, very positive.
But actually, we promised the audience that we would come back to how we evaluate FFRs in serial stenosis, which will actually basically most often be the case in bifurcations. So what should we really conclude here?
Well, the first thing to say is serial stenoses are difficult to assess with pressure wire.
Yeah.
There is no hidden secret, I don't think. And ultimately, I'm afraid what you've got to do for most cases is to treat the tight one and then measure it again. There's no trick to that, I don't think. What you can do, which sometimes gives you more insight, is to do a pullback, or there are versions of that in some of the softwares, and look at where the jump is.
Yeah.
And the area of the biggest jump is the area probably you should start with your stent. It can be very, very difficult to know exactly how to treat serial stenoses, but probably the best scientific way to do it is that pullback approach, either physically pulling it back and watching or using one of the available software packages.
So we have a great guidance help in physiology, but there are pitfalls. And I'll be a bit more mean because now we are discussing serial stenosis. And if we consider this case a Medina 110 or 101 and define the main branch as the obtusus marginal, then it's a 110. But then the serial stenosis is in the main vessel and in the main vessel. But the side branch is also part of the measurement when we are measuring FFR.
Importantly, the fact that the pressure wire in the 0 is positive does not mean it requires a stent.
Exactly.
Because the reason it's positive is the first one.
Exactly.
Yeah? So that we need to remember that you really can't use pressure wire. You can use pressure wire for a lot of things, but it is not the right way to design and to decide whether you have to use 2 stents. That's not the way to use physiology.
Exactly. That's not this result.
So what you're telling me is actually that we need to put the measurements into perspective, and we need to be very precise where we are in the procedure when we use the guidance from the pressure wire. So it's one situation when we evaluate the case from the beginning, but it's another situation when we actually have put in the first stent.
Right.
Yeah.
So we're still in the decision phase at the moment.
Yeah.
This tells us we need to treat.
Exactly. And we will do it step by step. And at each step, physiological assessment.
We have a question which actually talks into, well, some of the pitfalls of FFR measurements or indexes or physiology. And it says, can you use FFR, IFR in an ACS setting? Which is actually a very good question with a very difficult answer.
Well, it is difficult and it's not entirely clear. I think the simplest answer is if your physiological index is positive in ACS, then you can treat it.
Yeah.
So that's simple. If your physiological index is negative, it's more difficult because ultimately this can be a hot lesion. It may not be necessarily flow limiting, but it is a hot plaque which is more prone to occlusion. And so we're not determining whether this is going to cause angina. It is the risk of vessel occlusion that is the issue. That characterization of the plaque might require imaging better than physiology. So clearly, if it's 0.81 in the LAD and it looks bad on the angiogram, and it's an ACS situation, I might treat it. Whereas in a stable situation, you wouldn't treat an FFR of 0.81 in the LAD. That's outside the treatment threshold. So I think there are still some uncertainties about how to use ACS, FFR or pressure wire in ACS. But I don't think anyone would argue that if it's pressure wire positive in ACS, you should treat it. It's how to measure, particularly how to treat these lesions in the grey zone in ACS where there's some debate.
So it would be fair to say that use of FFR wires in ACS makes sense, but we have to, well, evaluate the result with a bit cautiousness.
Right.
And we have to remember that almost one half of the STEMI lesions have a negative FFR the day before.
Yeah.
Right.
So,
which is really important.
Yeah.
Yeah. Very good. But let's move on.
So this is how we treat it. We predilate the main branch, the main vessel in the main side, in the main branch, with a 2.5 millimeters balloon, predilatation and implantation of a quite long stent, long enough to do a pot in the proximal vessel. So this was a 2.5 by 33 DES, 14 atmosphere. So 2.5 thanks to the diameter of the distal main vessel. And then the proximal optimization technique with a 3 millimeters balloon, according to the proximal side. This is the clear stent, which is perfectly showing the difference between the proximal and the distal vessel. And then at this point, we jail the FFR wire beyond the struts, and we assess the FFR of this side branch, which was 0.79.
And you're comfortable jailing these new wires?
I would say with modern technology, which is a coaxial core and a fiber optic, yes, I am, and we did it a couple of times. But with whole technology, I wouldn't do it.
Well, yeah, because having been part of the Nordic 3 trial, actually I get a bit anxious every time I see a pressure wire jailed. We had some incidences there where it caused us problems, and I think it was one of the reasons that the older generation of wires was not very popular in jailing. And actually some of the Korean studies actually pointed to the fact that we may not need that assessment. But things move forward.
Exactly, and this case is a good example how the technology is disruptive and how this wire is close to a workhorse wire, because we stent it, we jail this wire, and we disconnect it to pull back in the main vessel and to recross the side branch in order to treat it. Because when we had this value of FFR 0.79, we asked ourselves, do we need to open this side branch or no? And we went for that. And so
So it's perhaps worth just kind of saying at that point, again, there's things we know and things we kind of don't know about how we assess the side branch result with physiology. We've said that it's quite common to see osteal stenosis in the side branch following the initial stent. And if we assess those osteal stenoses, often they will be physiologically negative. So we know that we can leave those alone. Where it's less certain is particularly here where we're in the grey zone, between 0.75 and 0.8 with FFR. What to do about that? That's a bit less certain. And certainly what I wouldn't do is to immediately reach for a second stent.
Exactly.
I think we need to think carefully, and probably the first thing to do is to think about the optimization in the proximal vessel. Have we done that optimally? Have we really made sure that that proximal stent is properly deployed? Because that measurement is reflecting the possible disease at the ostium of the circ.
Yep.
It's reflecting the proximal stent segment and the ostium of the branch. So that all of that segment is what's giving you the 0.79.
Exactly.
And of course, we may have touched to some extent the carina anyway,
Right.
if we did too deep a pod or too aggressive distal dilatation of the main vessel balloon. So there are of course considerations here. There is just a question addressing the pod sequence, and it is basically a very, very good question. To perform pod, where should we put the distal marker of the balloon?
It's a good question.
Yeah.
To the carina, but where exactly to the carina? I would say it depends also from the brand of your balloon. Is there a big shoulder or short shoulder? And that's what you were underlying. And you should put the shoulder at the distal part of the carina. That's what is recommended in EBC. Adrian, no?
Yeah, no, but not beyond.
Not
If you go beyond,
Yeah.
then you're going to overexpand the ostium of the main branch, and that will inevitably start to squash the side branch ostium. So one of the things that we have to remember is it's quite hard to place the pot balloon on a diagram when you draw it on a piece of paper. In a three-dimensional heart, to be sure that you're in the right perpendicular, to be sure where to place your pot balloon can be very, very difficult. And I think there is some jeopardy in, as we've just discussed, in distal pot that is too deep. So better to be too proximal than too deep. You really need to spend some time doing the pot, finding the right view, placing it carefully, and importantly, making sure that the very proximal cells of your stent as well have also been covered. Often the pot balloon is perhaps sized and is a little appropriately shorter than the stent in the parent vessel, and the cells more proximal to it may not also require expansion. And we sometimes forget to do two inflations in the main branch, which is really quite important again.
Yes, and of course, if we go back to the anatomy, there is the polygonal confluence in the bifurcation, where actually in the area just above the carina, the diameter is a bit larger than in the proximal part. So there are, of course, difficulties here, but just to address it clearly, know your workhorse balloon. Know where the marker is and know where the shoulders goes to. Point 1. Point 2, try to find the most optimal angle for visualization of a clear carina and not much overlap. It makes it a bit easier, but it's basically...
And a non-compliant balloon.
Which is very important, yes. But anyway, the angulation can be really challenging.
Yeah.
Okay. I think we should move a bit more on. Yeah.
So I'm showing you what we done with Jacques Monségu, my partner. We decided to open this side branch, and we use the same wire as I said. So the opto wire, we pull it back in the main vessel. We assess the FFR, which was negative at 0.91, and then we place it in the side branch, as you can appreciate here very easily. And then again, we had we would say positive or in the gray zone FFR at 0.79. So after the opening of the side branch and the report, we had this assessment of the FFR in the side branch, which was slightly positive. It's disappointed, but it's the real life. And then we assessed the main branch FFR to be sure that the proximal lesion of the circ was not the cause of this non-perfect FFR, post-PCI FFR. So the FFR in the main branch was 0.85, which is a bit disappointed, but it's maybe because of the proximal circ lesion, the spasm, the distal embolization. So sometimes you can have that kind of problem. And Jens, you know that the post-PCI FFR is not perfect.
It's hardly ever one, that's for sure. I think what we recognise is if we do FFR at the end of our case, there is definite sort of gradation. And one of the great things about FFR was it was binary. It was either treat or no treat. Mm-hmm. Certainly in post-treatment FFR, it's not binary. It's a gradation. That 0.85 is better than 0.83, and 0.83 is better than 0.81. It ideally should be more than 0.9. If you get more than 0.9, that's great. And we've done a nice series which we published in Neurointervention of looking at post-FFR results in complex disease. And frustratingly, there are times when the FFR is less than 0.8. And if you look with OCT, you see the reasons for it. Your stent is not expanded properly. You've not covered all the disease. There are things you can do quite easily sometimes. It's usually post-dilatation to improve the FFR. And clearly, we have to try very hard to get the FFR more than 0.8. But there is a difference, I think, in outcome if you can get it from 0.81 to 0.9. So it's about stringency of our results and making sure that we've really done our best job. So here where we've done a pot, we've then done a side, we've done an inflation of the side branch. We probably need to do another pot, don't we, to make sure that we haven't distorted the main vessel stent. Because ultimately, it is the main vessel which determines outcome. I mean, sure, in this is perhaps not a good example of it, and you've got two vessels which are broadly the same sort of size, with probably the same sort of distribution and responsibility for myocardium. But in general, in an LAD diagonal bifurcation, we must take care of the LAD. We want to keep the diagonal open, but the LAD is absolutely key. And so the main vessel is absolutely important with regard to our stent optimization. So just doing pot side is probably not enough. We need to do pot, side, pot. Make sure that main branch is optimal.
That's exactly.
But Benjamin and Adrian, you're now embarking on the very specific issue on the technical problems when addressing the side branch by ballooning. Yeah. And according to the EBC, pot side pot works, but there are two problems with pot side pot. The first problem is actually that the side branch dilatation will disembark the main vessel stent from the opposite vessel wall. And the other thing is that to correct that, you need to go very deep with your second pot, which give you a high risk of pushing the carina back to where it come from. And then you're back to basics again and can start all over once again. So pot side pot works, but it's a technical, not that easy and not that forgiving technique to do. On the other hand, you could do kissing.
Exactly.
Yeah, and kissing would, I guess, have been feasible here as well.
Exactly. Kissing and after pot.
So kissing in a final pot.
Yeah.
And a final pot, yes.
And that, of course, the rationale for that is that with the kissing, potentially you end up with a sort of barrel-shaped main vessel, but you want to make sure that that's round. So kiss pot, and again, making sure that your pot then definitely is slightly more proximal, so that you've optimized the proximal vessel again. So kiss pot, for the reasons that I illustrated earlier about being able to see where the balloon is in the bifurcation, certainly in my practice, I would tend to kiss pot rather than pot side pot, personally.
Yeah, and actually, I do actually the same. Maybe not in this situation here. I guess I may have ended up with a pot side pot as well. But in most bifurcation, and I do it for this simple reason, that a kissing is very, very safe, and it places the carina in the middle.
Yeah.
And it allows me, I do a very, not too high kiss. I tend to put the balloons within the polygonia of confluence. And then it saves me room for a more proximal pot in a safe distance from the carina. So that actually is technical, not that demanding, and it's more safe. But of course, there's one thing with both of these techniques that we have to be aware of, and it's the risk of bottleneck phenomenon. If we pot put the pod balloon at the final pod to the end of the stent.
Yeah, it's tricky.
And not too long, of course. So that was actually some of the very, very well put points for the provisional philosophy. If we ended up here, if we should put in a stent in this situation, it would be easily done. But if we had an FFR value of 0.79, and what did we do?
So in that case, it's very interesting. We have a positive FFR, but it's in the gray zone. Yeah. It's the side branch, it's a small territory, and we have a main vessel which is quite good physiologically assessed. Yeah. 0.85. It's acceptable, and you know that there is a proximal sock lesion. So you say that this proximal lesion is causing this non-perfect FFR. So we choose to let it like this, and we will see how it comes. But we decide not to treat the proximal part of the SIR, not to treat the left main. And this is the simple way of treating bifurcation.
And there is another beauty of this strategy, because if you put in a stent, it's very difficult to take it out again. Mm-hmm. But if you don't put in a stent, you can always come back and put it in if you need it. Mm. So you can just be clinically driven.
Step by step.
Yeah.
There's certainly some data from Excel looking at stent lesions which were not true bifurcations. So not 111, either 101 or 110. And they did less well with 2 stents than they did with 1 stent. Yeah. And so, sure, we all recognize that there are bifurcation lesions which require 2 stents, and we understand that. But when you can treat with 1 stent, the outcomes are usually better. Mm-hmm. And
of course,
there is also data to support the hypothesis that putting in a second stent, in fact, sometimes jeopardizes your main stent result. So it is sometimes a tricky decision, but I would support this decision in this case, where we've done our best to optimize the stent, and we've got a pretty good result physiologically, actually. So I think that's pretty good.
Yeah, and we can, of course, discuss if 0.79 is really significant. Right. Yeah, because it's in the gray zone, and it's very, very close to not being in the gray zone, which, of course, also is an illusion. But anyway, we have some questions that addresses the use of physiology still. So one from the audience asked us, why was FFR performed upfront? Does that influence our stenting strategy?
We already answered to that. No, it didn't modify our strategy. Our strategy was quite clear to try to treat the main vessel from proximal to distal. And the main goal of this FFR wire was to assess the FFR after stenting and after pod. That's why. But we have it on the desk, so we assess the FFR.
It's quite a nice example of how this new wire allows you to do things you wouldn't normally do. Exactly. And that's the difference here. You weren't using it to determine your strategy, but you had it there to assess the side branch once you'd stented across, which, it's just this evolution of technique with the new wires.
Yeah, but there was another thing, because we could argue that if we shouldn't use FFR, the evaluation was done only by the angio.
Exact.
Yeah. And of course,
like usual.
Like usual, yes. But actually, I learned a lot by doing FFR-guided PCI. Some lesion that I thought was non-significant showed up to be significant, but even more lesions that I really thought was significant turned out not to be. So we learn. So it's not only the anatomy that gives the clear answer. But I think it's a teaser, because the next question from the first was actually, why was FFR performed upfront? And the next question is, what if the side branch has a significant stenosis? Would you still use FFR to estimate the main branch stenosis? And I think it talks into serial measurements again.
Yeah, I mean, I think it depends a little bit what you're calling side branch and what you're calling main branch, doesn't it? I mean, to be honest, what it tells you, if the side branch is positive, is it's going to need a stent somewhere in the bifurcation. It doesn't necessarily still mean to me that it has to be a 2-stent bifurcation. I think that's what the EBC trial is looking at. So EBC2 is a left main trial, as you know, looking at 1-1-1 left main bifurcations and deciding whether we can treat those safely with a provisional strategy. That trial is about 3/4 recruited, and we hope that we'll finish recruitment around Christmas time, and that will give us a really definitive answer, I hope, to that question, which is for a 1-1-1 left main bifurcation, is it safe to use a provisional approach?
But we could understand a different way the question.
Yeah.
The FFR in that case was the same before and after side branch ballooning.
Yeah.
And maybe the FFR was the reflect of the proximal lesion. And we didn't know that before, but we keep not stenting this side branch, and we assess in the main branch to understand why this FFR was positive or in the gray zone, and that's why because the proximal suck was diseased.
Yeah. There is some clarifying question according that. So the first one, did you perform pull pack across the circumflex osteum? And the answer was yes, and there was a clear drop down there.
Exactly.
Yeah.
And no drift.
And no drift, which is very important. And the other question is, did you use intravenous adenosine or intracoronary agent in this case?
In France, we use all the time intracoronary adenosine.
Yeah, so this was hemaemic measurements.
Yeah, exactly.
Yeah, but as we stated in the beginning, this is just a discussion on where we can be guided and not necessarily of the different indices.
But
So-
this pressure wire helps the interventional cardiologist to keep humble, because you have a perfect angiographic result and your FFR result is not perfect. It's hard, but it's the real life.
Yeah.
And it helps us to optimize the result.
I have to say, I think I don't really like intracoronary adenosine. I think it has more operator variability.
Yeah.
So I would put, I don't really mind about FFR with intravenous adenosine or resting indices, but my least favourite is probably intracoronary FFR, intracoronary adenosine FFR, because I think it can be very difficult to interpret. It just flicks and 0.70, was it 79 just for a second there?
Yeah.
And it can be quite difficult, I think.
Or was it a pause of 10 seconds? That kind of things, yeah. So intravenously gives a much more safer evaluation.
I think so.
Yeah, I think that's the general agreement. Yeah. Well, very, very nice case, and very, very instructive on how to do the procedure stepwise, guided by the knowledge of anatomy and guided by the physiology during the procedure. So, Benjamin, what is actually, if you should give one take-home message from this case, what should that be?
So my take-home message would be that this new generation of fiber optic FFR wire has changed my practice on treating bifurcation. It's more simple to treat it with a wire like this, because you have a reliable technique, reproducible, and you have a almost workhorse wire into your hands. You can disconnect and reconnect many times, and it helps me to try to avoid some unneeded stent on the side branch, especially.
Yeah, very good. And Adrian, what would you pinpoint from?
Yes, I think it's just an example of how, particularly as we move into more complex disease, we're moving in more and more into what used to be surgical disease, how we can use physiology not necessarily to do more complex things, but to do things more simply. And very commonly, simple is best. And if we can try to keep to making sure we only treat lesions that need treating, and we only need to use one stent rather than two, then I think our patient outcomes will be better and safer, particularly in the long term, I think.
Very, very well. So what have we learned today? We have learned, actually the take-home message is that you have not just been through, but we have learned how to evaluate the philosophy behind the provisional stenting, how to keep a procedure simple but not too simple, and how to let us guide by, of course, the anatomy, but even more important, guide by the physiology, which have been more easy with a newer generation of wires. So there are different steps in bifurcation stenting, where we really have to underline the gain we have had. It's in the initial lesion treatment and evaluation, we have the guidance. After putting in the stent in the main vessel, we have a new opportunity to evaluate the side branch, There are pitfalls, but we can be guided. And of course, the consideration of how to take care of the side plan ostium and do a proper pod and maybe a repod. We have also seen a lot of support in the physiological measurements. And finally, for the final assessment, and here we have to underline that an FFR of 1 after treatment is basically an illusion, but it should hopefully be much better than before we embarked on the procedure. So, on behalf of my colleagues, I would like to thank Opsens Medical for supporting this program and making this procedure easier. All the best from the three of us. Thank you very much and have a good evening.